Welcome back. We oftentimes hear of Lisfranc injuries. Some are subtle, some require surgery, and some are just difficult to diagnose and manage. You just have to think about Cam Newton and yesterday Steph Curry with his midfoot sprain. So Vinod Panchbhavi is going to be moderating this session and talk to us about Lisfranc injuries and hopefully provide us all with some enlightenment. Vinod, it's all yours.
Thank you, Selene. Thank you also to my panelists for joining in. And I'm going to say this would hopefully be a truly international panel, as you can see.
And Vinod, I also did want to actually thank Biologics. So I apologize for cutting you off, but thank the panelists and Biologics for sponsoring the session.
Got it. Thank you. So as you can see on the panel, we have folks from different parts of the world. I'm hoping still that a couple of folks who have not yet joined might be able to join through, shortly. We have Mr. Harvinder Bedi. He is an orthopedic surgeon from Melbourne, Australia. And I have interacted with Mr. Bedi a few times. We traveled in India as well. And, he's a great speaker, a great surgeon. And welcome, Harvinder.
Thank you very much.
I hope we will, be able to see Mr. D'Souza. He's from Ireland, and I spoke to him briefly a few minutes ago, and he's probably logging in as we speak. Dr. Cristian Ortiz is supposed to join us, but I'm not sure whether he can or not. But we have Dr. Lundeen, and I have interacted with Dr. Lundeen on several occasions in several formats, and always humbled by his humble nature, despite his wealth of knowledge, and I look forward to interacting with him on this panel and learning from you all. Again, I want to tell the audience to be interactive and use the chat box to share their experiences and ask any questions you have. And I want this next hour to be truly interactive, and we'll present cases, and we'll see what we need to do, and if we don't do what should be done, and what can lead us into problems. I have some interesting cases. Again, some of them have been shared by the panelists here, and we'll see where we go with this talk or the session. So like I said, this will be a case-based session, and through an interactive discussion, not only with the panelists, but hope to involve as many possible from the audience, who will enlighten the principles of management and go through the imaging challenges we have, surgical strategies, and also hopefully highlight problems when we do not diagnose these cases appropriately or in time, or if we diagnose these cases, what can lead to disaster if we do not fix them well. So here, let's start with this particular case. This is a gentleman who had a significant injury, and he presented to ER with this kind of scenario. Let me see if we have his other X-ray. This is his AP X-ray, which obviously the experienced eyes can figure out what's going on. But, but for those who don't look at these fractures or see these patients, sometimes it's difficult to pick out the problem at this stage. I don't want to put anybody on the spot, but this is the report on this X-ray. So you can see there is no acute fracture or dislocation is seen. This is a radiologist reporting on this. But the experienced folks on the panel and in the audience can figure out what's happening. And the talk is on Lisfranc injury, and you can already see some of the soft tissue swelling you see over here. And obviously you need to know where is Lisfranc ligament situated, and anatomic location of this ligament, and what bones it binds to. And if you focus your attention there, you might be able to figure out what's happening. But unfortunately, this patient was not picked up at that stage. As you can see from the previous, the date, so you can see the date here is September, and then it comes back in October, a few weeks later. And at this time, they have taken a weight-bearing X-ray. And at this stage, also, one can, again, the experienced folks can figure out what's happening at this stage. And this is what we do. I mean, if you are not able to see things on the non-weight-bearing X-rays, one would like to do weight-bearing X-rays if the patient is able to bear weight. Let me bring in our panelists here and at this stage and want to know, is there anything different you guys would do at this stage, or you have the diagnosis, or you have a management plan at this stage? Let me ask Harvinder and then Gregg as to what are your thoughts at this stage?
Sure, certainly the films do show that soft tissue swelling that you pointed out. There's certainly an irregularity, certainly at the base, at least of the second TMT joint. You can't see the lateral cuneiform very well, but this may well involve the third TMT joint. On the previous film, it was a little hard to tell once again, but they look like there may be some additional injury to particularly the lateral portion of the medial cuneiform. So in essence, I think we need a little bit more information, and I would suggest a CT scan at this stage. But the other thing that's always very important is a clinical examination. Patients like this will often have the plantar ecchymosis, the plantar bruising. That's a telltale sign. Sometimes if it's a significant eversion injury, they will sometimes have additional tenderness, even more proximally. So these are associated with lateral-sided ankle injuries, sometimes even syndesmotic strains, etc. So first thing is the examination, and then the second thing is to determine anatomically what's going on with the CT scan.
Got it. Gregg?
Yeah, I would agree. I think when you look at the base of the second there is that what looks like maybe a flex sign on that first non-weight bearing X-ray, which would be a little bit concerning to me. And then on your weight bearing X-rays, you could see that as well. So I would certainly lean towards some concern for an injury. And then with that weight bearing X-ray, you can see maybe just a little bit more diastasis between the base of the second and the first metatarsal and second. So I think there's enough radiographic concern that I think advanced imaging would be warranted.
Absolutely. I mean, that's what I said, folks who are used to seeing these X-rays, easily can pick that out, you see, despite, obviously I'm not going on about this radiologist who said no acute fracture or dislocation, but you can clearly see there's that flex sign there. And as you notice, there's increased diastasis already. So now this patient was sent back again and then comes back again. Look, doc, my foot is not right. Now here you can, obviously, even the radiologist now can figure out what's happening. You can see there's a dorsal opening, which shows that there is instability at the base of the first metatarsal cuneiform joint, and which is expressed even in this picture. So you can see the medial border of the first metatarsal base doesn't line up with the medial border of the medial cuneiform, and you can see increased gap. There's something else. You see, I mean, obviously, whenever these injuries occur, there is a severe abduction force. So just like the entry of a bullet, you have an entry and an exit. The force, or I like to say, if you have a typhoon or, or a, what do you call those things? Tornado, you see, so you have a path of destruction. So here you can see the path of destruction started off from the medial side of the midfoot at the junction of the first metatarsal cuneiform joint. It has taken off the base of the second metatarsal. And as Harvinder has already seen, there's something else happening further lateral. If you go all the way lateral, you will see something else happening. The fracture in the cuboid. So that's the exit of that, the path of the tornado, or the exit, so this is a transversely unstable, transversely and dorsolaterally unstable Lisfranc injury here. So this is the mechanism of injury. Unfortunately, obviously, even at this stage, I think one can have a good result. We'll talk about the management strategies. But you see, unfortunately, this patient went down.
So based on your radiographs and the series you're showing and how this was missed, somebody had a question. How do you differentiate your ligamentous Lisfranc injury when you have an associated flat foot? How would you guys suggest doing that?
So the question is, how do you diagnose a ligamentous Lisfranc injury when associated with a flat foot?
Correct.
That's a great question. Absolutely fabulous question. Now, sometimes, you see these patients with severe hallux valgus deformity. And you occasionally if you take a weight-bearing X-ray, you will find that there's a big gap there, but the patient has got no problem there. See, so in a flat foot, there is always a bigger gap. In a cavus foot, on the other hand, other extreme, you find a very little gap between the first metatarso, second metatarso, and cuneiform joint. Maybe it's a projectional or whatever it is, but the gap is much more there radiologically, even though it's not injured. You can have that. So to diagnose, again, what Harvinder Bedi has suggested, clinical, starts with the obviously mechanism of injury, a good clinical examination. There's a soft tissue swelling, there's a plantar ecchymosis, and there's a tenderness down there. We are leaning towards the injury of the Lisfranc ligament. And, if the weight-bearing X-rays show differential diastasis, then again, it helps us to diagnose towards the disruption of the ligament. And you can have further investigation modalities, including MRI scan, or if we're taking the patient to the OR, you can do a stress X-rays. I want other folks to weigh in if they have any other suggestions.
Well, and that leads into this person's second part, which is how much joint disruption is sufficient to call it a Lisfranc injury.
Okay, yes. I'll let other panelists speak, and I do have a couple of great slides on that particular thing. But let me see what other folks would like to add to. Do you go by a radiological parameter? Do you say, like we talk about sometimes in syndesmosis, if you say 2 millimeter gap or 3 millimeter gap or 5 millimeter gap, is there a radiological gap which defines, yes, this is injury? Can that be a clinching thing? Or should you hang your hat on that particular number? Or should you, again, what we already said, go by everything else? Is there a number?
Right. I think it's based on pain. I mean, I think it's how the patient's doing. I don't think you can rely on a particular number based on, our conversation just a few minutes ago about foot shape and how flat feet and cavus feet have different radiographic appearances in that area. And so, like, if a patient has a reasonable mechanism and they have pain, then I think it requires further intervention.
Like I said, yeah. Harvinder, anything else you want to add on that?
Yeah, I'm going to add some controversy to this. Okay, so if someone's got, I think that is a fantastic question, that flat foot with the relative laxity through the midfoot and how to distinguish whether you need to do something or not. So you certainly need the clinical assessment, weight-bearing radiographs. I'm very fortunate I have access to a weight-bearing CT scanner, which will do 2 feet simultaneously. So having had the patient wait a couple of weeks or so with these more subtle things until they can put weight, so you can see whether there is asymmetry in there. Now, not everyone has access to that. We've been partly using that as a research tool. But look, historically, we've talked about 1 millimeter or 2 millimeter and things like that. Now, if you look at the data, to me, this has been solved a lot by initially Chris Kurtz's paper that suggested that ligamentous Lisfranc injuries did poorly when they were fixed and that primary fusion could be considered. So in a sense, and as I said, I'm going to add some controversy to this, if the patient is in pain, as was pointed out, that pain's persisting and functioning poorly, and they've got evidence of some level of diastasis, call that a couple of millimeters, I think that's a reasonable indication for intervention. If they're not that sore, and you're not certain whether it is going to become sore or settle down by itself, in a sense, if you take the philosophy that the best treatment for these subtle ligamentous injuries, if necessary, is to go on and fuse them, then in a sense, you've got 3 months to wait and see. And they will declare themselves in that period of time. If you're a believer that early internal fixation of these ligamentous ones, right, is going to make a difference, and that's the best treatment. That's when that difficulty arises, 2, 3, 4, 5 mils. But if you, as I said, if you look at the data, these ligamentous Lisfranc injuries, I would say that there's more data to suggest that primary fusion, when you have to do it based on clinical progression, if you consider that that's the definitive treatment, in a sense, it's a solved problem, because you can leave them 3 or 6 months and find out what happens. There you go. There's going to be an alternative due to most.
Wonderful. Yes, I think we'll come down to fusion or fixation later on. But you're right, it still remains controversial. I don't think everybody, the problem is not yet solved. But I think in early stages, certainly we can't just base our diagnosis on pure radiological findings. Sometimes you see, there could be a diastasis without an injury at all, because the patient has come for something else. And I've lots of examples of flat foot patients who have a increased or like 3 millimeter gap without having an injury down there. So that's what I see in the flat foot patients versus the diagnosis in a cavus type. That's another challenge in itself. So let me move on. But this particular case tells us, you see, if there is instability, there is going to be a drift. You see, so you can see how this particular injury, there is a medial capsular ligamentous injury. There is a Lisfranc injury. There's all the capsules and ligaments between the tarsal-metatarsal joints have been disrupted. And you can see how this has gone on to become malunited. You see. So within a few months, this particular patient at this stage is much more difficult to get a realignment. Even if you fuse this, it's quite challenging to do that. But at this particular stage on the left hand side of the screen, it's much easier problem to solve than if you have left it. So missing these injuries has consequences. Now, about the fixation strategies, I'm going to go through some of these cases. First of all, to show what probably should not be done, and then we'll go on to cases by panelists who submitted their cases to see what should be done. So here is a case. Let me see. Start off this time with Greg. So what is your friction? I mean, obviously, we know there is instability down there. You can see on the lateral X-rays, if you draw a line on the dorsum of the navicular and move distally over the medial cuneiform, then there is a step off at the second metatarsal base. You see? And then you can also on the AP radiograph, you can see a diastasis between the base of the second metatarsal and the medial cuneiform, and there is a tiny fleck as well. So there's no doubt that this is a Lisfranc injury. Now I have a question here. Are there any further investigations necessary here, or should you get it, or will it change your management at this stage? Or do you say you have enough to take this patient to the OR and do what you need to do? So the first question would be, are more investigations warranted at this stage or not? So Greg, what's your opinion? And then I'll ask Harvinder to weigh in.
I always like to get advanced imaging, and I'd say I probably don't feel like I need it maybe 90% of the time, but it's those 10% of patients that make me keep wanting to do it, where I see a surprise on there, like, oh, I'm glad I got a CT scan or an MRI for that. So I routinely get advanced imaging prior to going to the operating room, just to make sure I fully understand exactly what the injury pattern is. And then as far as fixation, I would go in, I would primarily use this one. I would realign the first ray, get that perfect, and then bring the second over. And looking at that lateral, I'm a little bit nervous about the third, thinking that probably is off also and unstable. And I would evaluate that in the operating room. I'd probably do your one big incision over the top and get access to everything, or I would do more of a dorsal medial approach to the first, and then a bit more of a lateral approach to the third and second, just so I had a good skin bridge through that. And I'd potentially base that on findings on the MRI or CT scan, particularly if I needed to get a little bit more lateral, like at the base of the fourth.
Harvinder, anything to add to this?
No, I agree. I would get a CT scan. You see surprises all the time. Sometimes you'll see a fracture additionally in the navicular cuneiform joint and a fragment that you might need to get out. I think that certainly CT scan's worthwhile. The other thing, to your point earlier, I think it's a very good one. There is always an entry point and an exit point. I don't know if that fourth metatarsal neck injury, I can't totally tell whether that's new or old. That might be the exit point. More likely it's gone through the lateral portion of the Lisfranc complex, but sometimes you'll get the reverse pattern. Rather than it exiting out through the lateral TMT joint, sometimes it'll come through medial naviculo-cuneiform, come across the second and third TMT, and then out distally. So to me, in a sense, it gives me a better idea of what I might need to stabilize. And if it's looking like that, I'll be even more attentive at extending my incisions and actually physically looking at the intercuneiform joints and the naviculo-cuneiform joint, just in case it needs stabilizing as well.
Absolutely. You hit on another important aspect of realizing the mechanism of injury and the direction of the pathological or destructive forces. You see, so what you pointed out, and there's sometimes, there could be vertical oriented injuries. So you could have disruption between the first and the second base of the metatarsal, between the first and second cuneiform, and it can exit between the naviculo-medial cuneiform joint as well. So, you could have instability between the medial cuneiform and the navicular. Sometimes it will skip the joint. You see, so it will skip the joint between the first metatarsal cuneiform joint. So, I get most of my information on the stability by manipulation and intraoperatively. So you see, when you just follow the path of destruction, and then you can see which joints need to be stabilized. Fluoroscopy, in my hands, is a better tool to diagnosing as to what joints are unstable and what joints I need to stabilize. So that's what I rely on heavily. So let's move on with this case, and I want to show what was done on this case. So you see here, the surgeon has decided to put a plate on the first metatarsal cuneiform joint and a screw traversing the second metatarsal cuneiform joint, you see. So is this adequate? Would you think the surgeon has stabilized this enough? That's the question we have. What do you think? I mean, would you take this patient to revise, or would you say, well, let's wait and see what happens? Or
Vinod, it looks like Lester may be online now.
Oh, wonderful. Can we get him?
Can we check?
Yes, please. Yeah.
Morning, guys.
We don't see you. Can you turn on your camera, please?
The camera is on.
Let me send a text to Selene. Oh, there you are. Hey, Lester, thank you for joining us.
No problem. I've been listening to all the conversations in the past.
Oh, wonderful, wonderful. And tell us where we have been wrong so far. Tell us, enlighten us.
Interesting, yes, interesting. I'm learning a lot too. Looking at this radiograph that you have put up, I think that fixation is totally inadequate. I think to start off, what do we do next is the question. And I think a CT will probably clarify the situation here to see what other injuries that are present. Certainly TMT 1, 2, and possibly 3 are unstable. And I'm not sure about 4 and 5. And I'm not a transarticular screw man. I prefer to plate the joints. And it served me very well over the years with very minimal complications of arthritis. Whereas transarticular screws, again, is controversial, has given me immense problems. I've had to go and take out the screws and subsequently fuse. So I prefer to stabilize the first 3 rays with plates and possibly wires for 4 and 5 if they're unstable in theater. That's
probably a wise advice here. Certainly there is nothing there, where it matters. Really, we need to stabilize. I hope you'll all agree. We have to have something between the first metatarsal and the medial cuneiform, second metatarsal and the medial cuneiform, which is where the Lisfranc ligament is. The nature has given us a ligament absolutely at the place where it's absolutely needed, you see. So we have to do something to stabilize it. And I think that was not done here. As you can see, it's a very, very strong ligament. This is a cadaver dissection. You can see, this is the end of the distal end of the medial cuneiform, and that's the base of the second metatarsal. You can see a very strong, very wide footprint of the ligament there. And it's a very strong ligament. If you try to rupture it, sometimes it'll duck a double bundle there, you see. So anyway, so as you have all guessed, it is not enough, and this kind of screw backed off, and then the surgeon decided to go back again and put a screw across the first metatarsal cuneiform joint, first and second metatarsal, as you can see, as an indirect way of reducing the gap between the base of the second metatarsal and the cuneiform joint. And I just don't want to belabor the point, but again, this itself was not adequate, and everything fell apart. As you can see, there is a drift. You see, that's a drift, adduction drift, because the foundation has not been stabilized. The foundation between the base of the second metatarsal and the medial cuneiform has been ignored. Therefore, you can see there's a drift of the first metatarsal on the medial cuneiform as such, and then the second moves, and then the first will follow. So that was what has happened here. See, so obviously, and then the hardware was removed, and you can see, 3 surgeries, 15 months later, the patient is not better. I think patient should have been left alone. It would have been much better off. Anyway, but I wouldn't do that. Obviously, none of the folks on the panel. What about this fixation? I'm just throwing out some cases here initially as to what should not be done, and then we'll go to cases, which folks have provided here to say what should be done. So, what about any criticism or critique on this particular way of fixing? Lester, you joined late, so I'm going to ask you first.
Yes, no problem. As I said, these screws have failed me every single time when I first started fixing these fractures, injuries, and I quickly moved on to plates, and which have served me very well. Those screws do nothing apart from damaging the articular surfaces. You have to go in and take them out. Many of them break. Some of them you can't even take them out, and then you have to go and fuse them. So 3 operations for a simple procedure where you put in plates and be done with it. So I simply don't like transarticular screws. I know you have said you hate this fixation. We got it, Lester. So now, what about Greg? Do you have any? I suppose you are a plating guy. I don't know whether you're screws or plates. Which one do you favor?
Yeah, I'm primarily an arthrodesis guy, and I like to fix it with non-screws. So I agree with Lester that it's that I've gotten away from screws myself. These kind of every man, anywhere from flexible fixation to screw to bridge to fusion, and lately I've just been happiest with fusion. It seems the most predictable. I think one of the problems with this is, there's, even if you were a screw guy, there's inadequate fixation, into that base of that second, going across the Lisfranc, you're just putting those screws in there. And then arguably the same thing with the first case that you just showed, the reduction is off. And so, the data on Lisfranc, and it's old data, I haven't seen any confounding data to refute it, is if you don't get the reduction right, the patient function is not going to be right. And so you need to make sure reduction is anatomic first, and then you need to have adequate fixation.
Yes.
So this is a patient that I would assume would do poorly, even if they did well.
So we're getting a question, why not do a primary arthrodesis, and in what setting would you do a primary arthrodesis?
Absolutely. We'll come to that. I will remember that question, Selene. I just want to point out to this, there's this strategy with the screws, you see. You can see, I think this particular screw, which is the Lisfranc screw, is actually pushing the base of the second metatarsal away. Even if you put a clamp and don't squeeze the clamp or hold the clamp, sometimes if the direction is from the medial cuneiform down to the base of the second metatarsal, you can end up actually distracting the joint. And that's what exactly has happened here. You can see the medial border of the second metatarsal base is no longer lining up with the medial border of the middle cuneiform. And I think, as already has been spoken to, the screws not only damage the cartilage, the very joints you're trying to stabilize, but also may be counterproductive if you're not doing it well.
So
Okay,
Vinod,
yes.
we have a question here. The home run screw. When do you decide to go cuneiform to metatarsal versus metatarsal to cuneiform, and does it matter? You're one of the experts in this.
Oh, thank you, Selene. So I'm going to go with the reason. So I just want to fly over this. You know, we have gone over some great cases here, which tells us why we should not miss this, and if we should catch them, we should make sure that we provide stabilization which will hold down and which will get them anatomic union. You can see the bases of the first and second metatarsal are almost at the same level, which is a bad thing. And the patient is an adduction deformity. You know, the problems can go up the chain as well. You see, this guy now has got is another example here, poor fixation, and the ankle gets affected. You see, so I want to get back to what Selene has asked for with this particular case here, case example. You know, here, as Harvinder has initially mentioned, you see, you need to go with the clinical signs, and you can see this particular patient has got a plantar ecchymosis sign, and you can see there is a little bit of a deformity there. If you're a very careful observer, keen observer, you can see there's a deformity in the midfoot, swelling, and so on and so forth. You can actually visualize that gapping in the dorsal aspect of the first metatarsal base and the cuneiform too, and it's not much, but to me, this is unstable. This injury is unstable. So, you know, I know, you know, you might want to get a CT scan for this stage, but for me, in my hands, I take them to the operating room and stress these folks under image. You see, I know what joints I need to fix and needs to stabilize. I pay attention to the most important part of the midfoot, which is the Lisfranc injury. So this is the interactive pictures here. I'm going to run through a few of the slides, and we have opportunity to discuss further on some cases. So, you know, I tend to use a triangle just beneath the knee and localize the joint. You can see the C-arm image. You know, my tool, you know, is there in my hand and pointing to the exact location there, and this is what I do. And I put, and you can see this is the stress radiograph. I see that there is opening down there. If I stabilize this, the rest of the foot will follow. You see, if I stabilize the first ray and second ray, the rest of the foot will follow. That's my strategy. And I make one incision there, and I can. And when you do this, you will find that the capsule is disrupted already down there. You see, and it's extremely, you know, unstable joint, as you can see here. And that's it. My pickups are picking up on the capsule, which has already been dissected out. And you can see I temporarily stabilize that. And then, you know, this is to show that, you know, I use this particular approach for the insertion of the Lisfranc screw. And there are reasons for that. You can see this particular screw is going from the base of the second metatarsal into the middle cuneiform. That way, there are advantages, you see. So what are these advantages? You see, this is what I was taught with. You know, I mean, when I started off fixing these things, my mentor, Dr. Trevino, and others at that time used to put this screw from the medial cuneiform into the base of the second metatarsal. But, you know, I started doing this the other way around, and we published this technique. What I found was, you know, we are aiming from a smaller to a bigger target, and the longer threaded portion, which is in the medial cuneiform, it gives a better fixation. And it's actually a denser part of the medial cuneiform, which we figured out. The other thing is, you see, if the fixation fails, it's almost impossible to remove the tail end of the screw. Whereas if it is a head end, we can take that out. So those are the advantages and the reason I choose to put the screw from the base of the second metatarsal into medial cuneiform. And I don't use the primary incision to put that. I make a small cut, as you can see, way lateral onto the lateral aspect of the base of the second metatarsal. The trajectory is much easier. You have less soft tissue disruption because you cannot get the trajectory from the primary wound. You see, so I make a small separate incision. So hopefully,
we got some questions pouring in here. So when you have, you know, you're showing the case before, you're showing the intercuneiform fixation as well as the Lisfranc fixation. what is your order? The home run screw first or the intercuneiform screw first? What's the order of what you do this? And secondly, how much damage do you think really occurs to the articular surfaces from the transarticular screws?
That study was the last question. The last Dr. Aronow, Michael Aronow, I think I remember his study. He's shown that at least if you say a 4.5 millimeter screw, and if you don't get the screw in the first pass, you might have second attempt to get the screw in a better position, so on and so forth. But I think percentage wise, I can't remember, but it is a substantial portion of that that is small joint, you see, especially in the second metatarsal cuneiform joint. I think percentage wise, it could be probably up to 30% of the joint could be taken up by one or two passes of the screws. If you don't get in maybe you have less percentage of violation between the first metatarsal and the cuneiform joint. I want to ask if others on the panel might weigh in on these questions. First of all, would you with the sequence? Obviously, the sequence. I have another case which will show the sequence and why we should do that particular thing. But are any particular strategies you guys use in sequencing? Do you go the first ray and the second ray and so on and so forth, or do you feel that you have to stabilize the medial cuneiform and second metatarsal base first and then move on to the other ones? Do you have a strategy or a plan or any technique tips you can provide? Let me start off with Lester, Harvinder, and then Greg. Lester.
Yeah, yes, Vinod, I always start with the TMT1 joint first, because you need to get the joint reduced accurately. Because if you have the first metatarsal sometimes fixed in dorsiflexion, you're going to have problems. So you have to get that right, get the first TMT joint stable, put a plate. I would then reduce the second metatarsal to the first, and then a home run screw, usually from lateral to medial, and then a dorsal plate for the second ray, and then a dorsal plate for the third ray, and then take it from there. That would be my sequence normally.
And what if there's an intercuneiform involvement? How do you address that? And at what point do you address that in your sequence?
Generally speaking, once you reduce the TMT1 and 2, the intercuneiform usually also is reduced, and I do not put a screw across the intercuneiform joint usually.
Okay. And for the other faculty members, if the second metatarsal base is comminuted with a fracture, how are you putting your home run screw in those situations?
Happy to take that. If it's very comminuted, I think one of the issues is that's one of the potential drivers to proceeding with primary fusion. I think as I am getting more old and grey, I'm fusing more than I used to. And certainly that is, if it was reasonably comminuted, that would reduce my threshold. I would fuse it and put a dorsal plate on. Now, having said that, you still need to address that Lisfranc instability. Although, having that said, once you've actually chosen to fuse the second TMT joint, the tendency for it to move off out of plane is certainly lower. I would still try and put in a home run screw. If that was not possible, then you may need to think about indirect stabilizing techniques to hold the first and second column together. Often, if it's more comminuted, there is disruption of the intercuneiform joint as well, so a screw across that, and sometimes putting in a screw between the first and second metatarsal through the intact portions will do it. It is all about making sure that column 1 and column 2 turn into one reasonably solid column.
So Greg, have you ever had a situation where there's so much comminution that you could put a screw from the third metatarsal base into the medial cuneiform? That is a question somebody's asking. And is that even a legitimate technique to do?
Sorry, my internet cut out just when you were saying that. I apologize.
Did you get the question?
Yes.
Greg?
The question is there ever any indication to put a home run screw, but from the third metatarsal to the medial cuneiform?
I just had bad internet again. Oh my gosh, I've been irritated with my.
Yeah, let me, the combination, I would question the mechanism of injury there. If you have a comminution, real comminution, the base of the second metatarsal into many pieces, it's probably a direct injury, like a crush injury. You could expect that. I don't think it's a like a ligamentous, or injury or a transverse force or adduction force or a abduction force, which is causing the damages. So, most of the Lisfranc, the sporting type injuries occur wherein there is a abduction force of the forefoot over the midfoot. Whereas a crush injury might cause a comminution, what you speaking about, which is a totally different scenario. Often there is a tiny speck, or there may be a big fragment, but that fragment is the the plantar and medial aspect of the second metatarsal. So you have a big base which is intact. It's almost like somewhat like a thumb Bennett's fracture. So you have that shaft of that which is always going to the base. The lateral wall of the second metatarsal is almost intact. I've never come across a situation in a ligamentous or a non-crush type injury wherein I'm struggling to put a screw. If that is the case, then I would fuse it. Okay, so I'm keeping an eye on the timing, and I have a few more interesting cases, and I think there is one case which will tell us how this can be a jigsaw puzzle, and how sometimes you have to line them up and then use our sequence from medial to lateral or whatever it is, but you have to probably have a preliminary fixation on first one particular joint across one joint, and then go on to the other joint. So let me get to this case which was given to me by Mr. Harvinder Bedi. And, Harvinder, you want to talk about this case? Obviously, as you can see, very briefly, there's a history there. A car ran over the foot. This probably sounds like a crush injury or something, but this is the scenario here. So, this is Harvinder's case. So let me bring in Gregg here, and what are your thoughts at this 70-year-old patient, dealing with a crush injury right here? So how would you manage this? Would you fuse it? Would you fix it? Or did you say, well, you're too old? I don't think able to say that, but.
Well, the older I get, the less too old is.
Yes.
So, obviously with a crush injury, the first thing I would be concerned about is the quality of the soft tissues, and are they even able to do surgery? Looking at the x-rays, it looks like, there's soft tissue swelling, but it doesn't look too bad. But if there was any soft tissue problems, I'd obviously delay any decisions. Advanced imaging, CT scan, clearly one is, at least 50% off, two might be 100% off. The lateral, you can see the dorsal displacement of the first and the second TMT joint. So, I think advanced imaging would be helpful. It probably has a injury across the entire TMT joints from 1 through 5. And then in terms of basic concepts of fixing, I would plan on an arthrodesis, realign 1, bring 2 to the medial cuneiform, get that aligned. I generally like to fix with plates or some type of plate type fixation rather than screws for my arthrodesis.
Okay, so this is Mr. Bedi's case. So I'm going to ask Lester, would you fix it or fuse it? Are you a person who wants to go for fusing or fixing? Would fixing give this person ability to get back to her, day-to-day activities sooner, or should you? There's only fusion which is necessary here.
I think the age is an important issue here, which needs to be considered. This is an elderly gentleman. You have one chance to get him right, and I think I would prefer to fuse him primarily. So it's all done and dusted, and I'd use plates to compress TMT 1, 2, and 3, and probably K-wires for a few weeks just to kind of let everything scar down. That would be my strategy. I would fuse this guy. I would use plates. I'll probably use some iliac graft just as supplementation, just in case if there's bone loss or crushing. But a CT will probably give me more information about this injury.
Would you? Okay. So, well, this is Harvinder's case. Harvinder, you want to tell us what you were thinking at that time?
Okay, so there's a few things. Obviously, this brings into the equation not only the issues with the foot, but this is a reasonably high energy injury, so we need to make sure she's systemically well, obviously. One thing that I did put this up for discussion, I'd be interested in the panel, including your views, is this came in pretty sore and swollen, got more swollen and more painful. Who decompresses compartments?
It's an interesting question, but for me, if there is obviously this is a acute injury, and for me, reduction of the joint is very critical. So some of the swelling which can appear to be a swelling is artificial there because of the dislocation of the underlying joint. So my priority will be at least to reduce the joints, and I could put a temporary K-wires and then come back at a later date and fuse them. But if I leave this for the swelling to go down and if the patient disappears and doesn't come back for 3 months, it's much more of a struggle for me to get them realigned to whether fix or fusion. So I don't do compartment syndrome. The compartment syndrome releases in the feet. I'm not sure whether other folks would do that.
No.
Mr. D'Souza, what goes on in Ireland? Do they decompress the compartments? I know I'm just a 70-year-old patient. What if this was a 20-year-old patient, soccer player from Ireland?
I'm the only foot and ankle surgeon for a population of 700,000, and I don't decompress them. But many of my colleagues who are non-foot and ankle surgeons decompress them and send them to me. And then it's a nightmare sometimes to close. It's difficult to teach them at this stage. So there is a notion out there that there is foot compartment syndrome. They need to be decompressed with 3 incisions. And I get these patients after decompression, but there's not a lot I can do about it. But getting them to close later on is a nightmare. So
interesting. Harvinder, take us further with this.
Yeah, I'm of exactly the same view. I think that compartment syndrome probably exists, but then you've got to ask, are you doing any good by trying to treat it? And I think that the morbidity that you create outweighs the morbidity potentially of some ischemia or clawed toes. So I was just seeing if there were any enthusiasts on the panel for that. So this lady did have a CT scan. That's what it looked like. Of those things we've discussed, the question is of immediate treatment, as you alluded to. I agree, it probably does need to, depending on the soft tissue, some attempt to try and improve the position and temporarily hold them with K-wires would be sensible and appropriate. And then the question is, how do we address this later down the track? And really the question is of fixation of reconstruction or a fusion. I think we've got pretty universal agreement that that's the case. And that's what was done.
Very nicely done. And I see that you put a K-wire in the fourth cuboid, and I presume it will come off in about 6 weeks.
Yeah, that's correct. That was just done because there was, on the CT scan, there was some comminution at the base, and I didn't want it to start riding back up dorsally, that's all.
I see Selene, there might be a question from the chat room. Is there one, Selene?
Yeah, it just came in that if you stabilize the first column and the second column and the intercuneiform, do you still need to provide a home run screw?
Oh yeah, definitely. We had actually shown a case wherein that was not done and it still drifted apart. So yes, my vote for that will be yes. I will stabilize the base of the second metatarsal to the medial cuneiform. That is, I think, most crucial than even stabilizing the third to the cuneiform. And I think if there is any disagreement, speak up amongst the panel. Is there a need to stabilize that particular screw, which Harvinder, I see that you have done that between the base of the second metatarsal to the medial cuneiform. I think it adds to stability. I would do that definitely. And like Harvinder said, sometimes I put a screw between the first and second metatarsal to give. Especially I'm trying to get a fusion in the first go round. Anything different from the panelists?
I think it depends on how you stabilize it. I mean, I think that the nice thing about the home run screw for me, occasionally, I'll use the U plates between 1 and 2, and I think you effectively stabilize it without a screw there. The nice thing about the screw is that you can hold your reduction, get the screw across, and then take your hands off of it. And then if you wanted to use like a U plate, you'll still have all that stability in your reduction that you're looking for. So even if you use a plate, I think the screw is a nice addition because it will hold your reduction while you're getting your plate in exactly the position you want, as opposed to trying to work around a reduction clamp.
Got it. So here's another case. As you can see, there is disruption, which you can clearly see, but the disruption is slighted in a different plane. This case illustrates, you see what I already alluded to. Disruption. There's a complete disruption there, and I sometimes temporarily stabilize the first metatarso cuneiform joint, and then put this plate and then this screw. So headless versus headed, you can discuss about that if you want to. And let's move on to Dr. Lundeen's, because I think we have about less than 8 or 7 minutes. So Gregg, this is your case. Thank you for providing this case. Let me see. Folks, anything can you see on this particular X-ray as such now? As again, obviously we're talking about Lisfranc injuries, and I think this is sometimes this is much more likely to be missed. And I think we stated before, and if the patient is unable to bear weight, full weight, you bring them back and then see what happens. Now clearly you can see the difference between the initial X-rays and the later X-rays. You can see there is an increased diastasis. Please add, Gregg, if there's, this is your case, you want to elaborate further on this?
Yeah, I think that it just goes along with, what Dr. Bedi said at the beginning, is you use your clinical suspicion as your primary driver for what you want to accomplish. And he could.
Cutting off. We are unable to, can anybody hear Dr. Lundeen?
Keep a really close eye on him, and I bring him back.
Okay. Yeah. So again, these are injuries which can easily be missed, and I see that you've got an MRI scan, or somebody. Sometimes what happens is the patient comes with an MRI or a CT scan already down there. How do you decide whether you want to go for MRI or CT, or is there a choice, or do you prefer one over the other based on some?
I typically like MRIs if I'm not seeing any fractures, because it gives me a little better look at the ligament injuries, so I don't miss the ligamentous component. If I see fractures like the original flex sign that you had that are a little bit more telltale, then I like to get CT scans.
Okay. Anybody else has anything to add? CT versus MRI, and what's their criteria to get one over the other?
I find that MRI scans confuse me. I find that if I want a justification for an operation, and I don't mean this as a criticism of this imaging at all in any way, but if I ever want to make someone have an operation, if you get an MRI scan, I can make something look really bad with all the edema and everything else there, but I never know what to do with it. So I think that the important thing is proving that it is unstable. I see I do a fair bit of sports work as well, and I see a lot of patients come in with some edema in the Lisfranc ligament, and I never really know whether it's disrupted or not. So I always like a bit of objective proof, be that weight-bearing X-rays, weight-bearing CT scans, possibly even EUA in theatre or something like that. I like a little bit of structural proof that something's unstable, because that to me is my indicator for whether something needs to be done, rather than the radiologist can't confidently tell you whether something's edematous, sprained, partially torn, or torn. I don't know, but maybe others have a different view.
Mr. D'Souza, do you ever get MRI or
No, it's never a first choice. I always start with radiographs. Of course, a proper clinical examination is important. Strong index of suspicion, clinical examination, radiographs. Ireland, unfortunately, weight-bearing radiographs, many of the patients simply refuse to bear weight the way I want them to bear weight. So I prefer a lot of them to take them to theater, do a good EUA, stress views. And many of them patients who have an MRI already have an MRI by the time they come to me, which I find singularly unhelpful because the radiologists are not very sure. As Harvinder said, they're not sure whether it's a sprain or is it a complete rupture. And I think EUA is probably where what I would use normally to diagnose subtle instabilities. So the quick answer to your question is I prefer radiographs, CTs, seldom MRI scans.
Greg, they are ganging up against you. Do you have anything in your defense to say?
And I would argue that I think with MRIs, I think you can actually see the ligaments fairly well, particularly on the coronal view, which I think is coming up on the next, where you can see the dorsal, the middle, and the plantar components, and then be able to determine the level of ligament involvement on that. So again, I think for these subtle ones, I actually find MRI to be more helpful than CT scan, because I think the findings that you're looking at this one, I think you would miss on the CT scan, with the exception of this medial cuneiform fracture on the base. So he had a subtle fracture at the base of the medial cuneiform.
Right here?
Yeah.
Yeah, I think they do have a place.
And then if you go back really quick, this is the view that you can actually see the ligament. So if you look at the T2 image, you can see that there's no plantar component to that Lisfranc, and that there's nothing in the mid portion. We've got 1 minute left, so we can just rally through.
Okay. So yes, indeed. So, I mean, this particular patient, I believe, didn't proceed with surgery immediately. So, if this particular case illustrates what do you do in a patient who, misses the boat initially, and comes back later on, and how long do you give before you decide, well, I can still fix this and get a good result, or no, it doesn't have any chance with the fixation, we go for fusion. Say a ligament, this kind of patient with a flex sign or a ligament injury, if you are a person who can get a fixation done, if the patient presents within, like, say, one or 2 weeks, if the patient comes at 6 months, for example, or 3 months later on, do you say, well, you can no longer fix it, you're just only fusion is the only choice, or do you still fix it? So I think there was a interesting paper also. I think, didn't you publish that, Greg? Fixing even in late presentation?
No, I just list that was looking at the data, that if you're gonna, especially if you're gonna fuse them,
you're breaking in and out. I'm not able to.
And I'm not doing it, but we are out of time. So
okay, yeah. All right. I think I enjoyed interacting with you folks. I want to thank Selene again. I hope we addressed the questions from the audience, and hope you can stay back and then answer some of these questions in chat box if you can. I want to thank the panelists for taking time off from their busy schedules and from all around the world in the middle of the night in some cases. I want to thank you for the interaction, educating me and the audience, and thank you again, Selene, for putting up a great show.
We appreciate it, everybody, and thanks to Isto Biosciences for sponsoring this session, and we'll sign off for the next hour.
All right, thanks everyone.
Thank you for the invitation.
Very much. Thank you.